To all who are new here, welcome to Releve Sports Medicine's virtual journal club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our upcoming schedule, so check back often. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure this is done timely in order to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The PowerPoint for today's talk is available from the dashboard. The recording will be available for review from our website tomorrow. Our speaker this evening is Assistant Professor of Rehabilitation and Regenerative Medicine at Columbia University Irving Medical Center and the Director of Dance Medicine, Dr. Iafrate, or Dr. J for short. She's a native from Ontario, Canada. She attended college in Canada at McMaster University and later moved to the United States to pursue a career in medicine. She received her medical degree from Midwestern University, Arizona College of Osteopathic Medicine, her residency in Physical Medicine and Rehabilitation at the Mayo Clinic, followed by a Sports Medicine Fellowship at the University of Iowa. She specializes in sports and dance medicine. She works with multiple dance schools in the area, and she will be speaking today about dance injury, diagnosis, and management.
Okay, hopefully you can all see my screen. I'm just going to put us up into full screen here, and I'm going to get started. Thank you for the introduction. I'm going to skip through this part because you just told everyone who I am. I do have a couple disclosures that I'm not going to be speaking of particularly with this, but I am a paid consultant and speaker for 10X Health, as well as a paid speaker for the Butterfly Network, which is an ultrasound company. Other than that, no other important things to discuss. Objectives, I think we sent out for all of you, and so you should have access to those, but these are our objectives. We basically want to improve your comfort and skill in the care of dance athletes. And so we're going to go through a quick history of dance, a couple of the styles and language of dance, and then just familiarize ourselves with the epidemiology, and then identify risk factors for some of the most common dance-related injuries and management options. Okay, so a lot of you should know what sports medicine is. It's care of the athletic population, which includes musculoskeletal injuries, general medical problems and concussions, sports PT, nutrition, psych, and prevention. But what about dance medicine? What's that? So dance medicine basically is this. Dancers are athletes that require really high quality care from their sports medicine medical team because they do things like this in class and then the next day they feel terrible. So they deserve the same kind of understanding of their injuries as all other athletes. And if there's one thing I can ask of you, it is know the terminology. So if you don't know the terminology, a lot of dancers won't feel like they can trust you. Okay, in terms of dance history, so ballet started in the 15th century in Italy, and then in France, the first school of ballet started. And then pointe was actually introduced all the way in the 1820s. Following that, modern dance showed up in around the 1900s, and then American ballet came in about 1934. And as of 2018, there's approximately 51, almost 52,000 dance studios operating in the US. So in terms of the culture of dance, dancers are athletes, right? And so Girls start at around age 4 to 9, and boys usually start about 12 to 16, so they show up much later. They're usually training seriously by age 8 to 10, and they're practicing about 10 to 15 hours per week of class. Pre-professional schools are usually affiliated with larger dance companies, and they act like a boarding school, basically. So these kids are dancing about 20 hours of class per week, plus cross-training. Professional dance in the US, there's an absolute ton of professional dance companies, and about 50% of them are here in New York City, which is why I decided to come here. And then professional ballet dancers, their average age is in their mid-20s, and this is a full-time job for them. They do over 100 performances per year, and men a lot of times more because there's not as many men in a company. So dancers are, yes, athletes, but they're also artists. So it's aesthetic, but also technical. They go to extreme ranges of motion, much more than a lot of our other athletes do. And there's an importance in terms of mentality, environment, and the screening. We don't really screen our dancers very well, and that's something we're trying to work towards fixing, as well as providing better access to care. So there's not a ton of information in terms of data on the demand of dance training and performance on the cardiovascular system, especially. Heart rate data does show that elite ballet dancers are usually at or near their maximal heart rates during performances. But a lot of the strength and power data is pretty mixed. And because there's so many different dance styles, some of these things get a little wishy-washy because their efforts are not as prolonged or sustained like they are in other sports. So very briefly, ballet, it's basically, you have to have a foundation in ballet training to be considered, you know, an elite dancer a lot of times for most dance forms, because technique is so important in avoiding injury, and ballet does involve a lot of technique. All these movements are in turn out and usually end up kind of getting self-selected if you have a retroverted femoral head neck angle, just because it allows for better turnout, which does lead to potential tissue injury, faulty biomechanics, and posture imbalances. We also want to watch out for sickling or winging. So both of these things involve breaking the line of the foot when you're either on point, which is up on their tiptoes, like this girl in the blue tutu on the far right side, or performing a tendu, which is when they stick their foot out in front of them and point their toes. So sickling is seen when the ankle rolls into inversion and the heel drops behind the leg, and that's usually due to an imbalance of strength. Whereas winging is more problematic when the foot is bearing weight, like in releve. So it consists of too much pronation or eversion of the foot, and all the weight gets pushed into the great toe. And so this can sometimes be normal if they're performing something like an arabesque, but really not at any other time. So like I said, pointe started in the 1820s, and Marie Taglioni was the first person to go on pointe in the Paris Opera. Jazz kind of started in this very interesting way. So it has roots in both African-American and Caribbean culture, and it's just become this modernized version of those two dance forms. Legs are typically in parallel or turned out, and it's very theatrical, and they tend to get a lot of back, hip, and knee injuries. Tap is high impact, where you make sounds with your feet. There's not a lot going on the upper extremities, but floor is really important here, as well as shoe maintenance. And ankle injuries are obviously very common. And that's a picture of me when I was a young child tap dancing. So I always think that's so cute. My mom sent me that picture. In terms of modern, so modern, I think of modern almost, and this is no disrespect at all, but this is like the emo cousin who shows up, like kind of a hipster. Like it was everything modern began as a rejection of traditional ballet concepts. So a lot of dynamic movements utilizing contraction and release of the trunk. They don't really use shoes. It's very grounded, and a lot of pressure and movements on the floor. So we think of people like Martha Graham, Horton, and Alvin Ailey. And then contemporary is just techniques that kind of utilize a lot of the legwork of ballet and then modern stress on the torso. So it's like a cute little merging of the two. A lot of floor work with this and fall and recovery. And again, barefoot, and very unpredictable changes in terms of the rhythm and speed of the movements, and they really focus on having good lines. So they get a ton of injuries, including the back, knees, ankles, and toes. And then breakdancing. So breakdancing was just introduced as becoming an Olympic sport. So it's going to be happening in the 2024 games, which I'm very excited about. Breakdancing or street dancing. Breaking is kind of like the OG. It started in the 1970s in New York, and now it's kind of an umbrella term that involves breaking, locking, popping, hip hop, freestyle, club style, commercial, bone breaking. So tons of different styles that kind of get involved. And in breakdancing, it's been noted that foot and ankle injuries were way less frequent than other styles of dance, and they see more the knee, spine, shoulder, wrist, and hand, obviously. If you learn nothing else from this lecture, please just take some time to learn some of the dance terminology. That little link right there does have a glossary that is pretty good. And then just learning like some of the positions in dance is really important. And then the one on the right-hand side involves like ballroom dancing. If a dancer feels like you understand them, they're gonna feel like they can trust you a lot more. So different dance styles involve different dance injuries, right? Different technical requirements, prerequisites, training models, shoes versus barefoot. So all of these things are involved. And yes, even twerking can cause back pain. I'm sorry. But there are multiple different dance styles, and I have listed a couple of the injuries that we typically see there. So in terms of epidemiology of dance, so injuries in dancers are obviously very common. The annual percentage of injured dancers has been thought to range anywhere from 67% to 95%, and up to 90% of them end up needing some form of treatment. And then up to 84% continue to perform even despite having an injury. A lot of the injuries are mainly non-contact or falls, and then professional injured dancers typically end up missing between 18 to 21 days per year on average. And this is their job. So they're missing 21 days of work because of injury pain. There was a study from 2014 that kind of looked at the typical injuries, and they found that ankle was the most common injured, followed by the lower leg, the foot, the knee, the hip and groin, and then the thigh. Again, this was based on more ballet and contemporary. And females were found to take a little bit longer to return to full participation than males, but that wasn't statistically significant, and that may have something to do with the fact that they had to go up on point too. Median number of days lost from dance is about 7, but the mean is 28. And the reason for that is because of outliers like stress fractures, which obviously we all know take much longer to heal. And then there was a study from 2 elite dance companies in New York that found that 100% of retired dancers had at least one injury during their career, which is a sad number to have to reconcile. So this was a cool little study that was done that aimed to evaluate the rate and characteristics of injuries among elite pre-professional dancers. And they found that the incidence of injury was 1.42 injuries per dancer. And the rate of injury compared to hours of dance was 1.38 per 1,000 hours. So joints were obviously most commonly injured, and overuse injuries obviously more common, which we expected to see. And then bony injuries were of course associated with the greater time loss. And then this little table at the bottom does show the most common injuries, and then the ones that had the greatest average time to return to sport and total time to return to full participation. Okay, so why do dancers get injured? So they're exposed to a ton of risk factors in dance, and there's a list of these that are some of the most common issues. A lot of it is duration of training and environmental conditions, and then the individual dancer's body alignment and biomechanics. A lot of times they're extremely flexible without compensatory strength to make up for that flexibility. And then interestingly, even the time of year sometimes has been called into question, because a study found that injuries were more prevalent in the first third of the season, suggesting maybe that transition from relative inactivity to intense activity may have something to do with some of their injuries. Dancers are also one of those early entry sports. So like gymnastics and figure skating, a lot of times because of the skill needed at such an early age, you end up having very early exposure to dance and kind of leaving other sports much earlier on than we would normally want to see. There's increasing rates of adolescent dance injuries because of this early specialization. And so this table just shows you that, you know, in order to be part of a professional dance studio, most of the females ended up starting before the age of 10, and then the males usually started around, you know, age 14 and later, or sorry, age 10 and later. Basically, it required them to become serious about dance very early on in adolescence, which created a major shift in their behavior and withdrawal from a lot of high school experiences, which can, of course, affect them from a mental perspective as well. And I think everyone on this call probably knows that there's a statement that came out about early sports specialization in terms of a consensus that it's not a good idea. Not everyone's kid is going to be the next Tiger Woods. But they did mention that gymnastics and figure skating, which by association I'm going to extrapolate to dancers, could be exceptions because those top tiers tend to occur during the teenage years and early 20s. So they said instead, consider participating in 2 hours a week of injury prevention training, which focuses on integrative neuromuscular training or different dance programs that exist. This picture makes me cringe every time I look at it. So the greatest risk for injury is exceeding 16 hours of total sport participation, regardless of the number of sports. So if you are doing any sport for more than 16 hours per week, you are at the greatest risk for injury. Technical demands that come with dance include those extreme ranges of motion and fine motor control, and that's going to even further expose them to higher risk. But there's not a lot of research that's directly extrapolated into dance medicine. So these are some of the risk factors. There's obviously intrinsic and extrinsic ones. I italicized some of the most important ones, including growth and flexibility, which we'll touch on, and then nutrition, and then obviously technique and training. So I put this picture up and now I'm realizing like typical dance presentation looks like an emaciated skeleton. No, that's not what I'm trying to imply. I just thought it was a cool picture. So, but usually dancers tend to be really tight in some areas and really muscular, and then really weak in those inhibited other muscles. So their iliopsoas, TFL, external rotators, QL, posterior tib, FHL, all of these are very strong muscles, but then the antagonist muscle to those tend to be really weak. Their glutes are not as strong usually. Their transverse abdominis, which is our, you know, truest core muscle, the multifidi, which tends to lead to back pain, and then the deep intrinsic muscles. They also tend to have poor rotatory stability and neuromuscular control, and dysfunctional joint mobility during movements. So some of the main challenges that dancers face include having a pretty short career span, which means they have to kind of push through injuries, and they tend to be perfectionists, and they're usually afraid of being told to stop. And then sometimes parents, I mean, we've all seen that show Dance Moms, which creeps me out too, but a lot of times they feel like they have to do it, otherwise their parents are going to be let down. Also, they don't have great access to healthcare, whether it's because they don't have doctors or clinicians or healthcare providers that have experience with caring for dancers, or they're just underinsured or uninsured. And usually their muscles can't really keep up with their growth spurts. So bones grow faster, muscles can't keep up, dancer experiences decrease in strength, flexibility, coordination, and technical control, which really causes a decrease in their confidence level because it's happening at that time where they're supposed to be, you know, planning to go into pre-professional dancing. And this can last, you know, even 2 or even sometimes 3 years. The other thing, like I said, overuse injuries are thought to result from exposure to repeated submaximal load without adequate recovery time. Dancers are exposing themselves to these kinds of issues with training levels that are in excess of the range that's recommended by the Academy of Pediatric Council on Sports Medicine and Fitness. So they're saying they should only be training a max of 5 days a week, and yet dancers religiously are practicing at least 6 days a week. Also, weight's really important here, right? And so body fat of the female dancer has been shown to overall, again, I'm saying more on the classical side of things with this statement, but shown to be, you know, 43% lower than their age and weight matched non-dancers. And in general, dance is so aesthetic that low BMIs are often favored. This picture on the left is Jennifer Ringer, and she was called fat when she was playing the Sugar Plum Fairy. They called her a plump, which I think is so offensive. And then this girl right here, she's a 15-year-old. Her name's Lizzie Howell, I think it is. And she has some of the best pirouettes I think I've seen. And she obviously is not a very slim girl. And so it shows that dancers can dance with a little bit more weight on their body as long as they have that good technique and strength to support themselves. So that poor access to care. So there's a study of doctor-dancer relationships, and there's been a couple of these, and they all basically lead to the same finding that dancers don't trust doctors. We tend to be kind of like the third person they think about behind their dance teachers and physical therapists. And we're basically falling marginally higher than their dance colleagues. And I think that's because of this culture of dance. It's like its own thing. They don't think doctors understand them. And I'm extrapolating to all healthcare providers don't necessarily understand them. And they don't have necessarily great access. If they're under their parents' insurance plan, sure. But then once they're professional, a lot of them are really underinsured. Again, another thing that shows you that trust is important, and we don't have it yet. We haven't garnered that yet. The youth dancer. So we said there's a growth spurt. It coincides with the time of increased intensity, can last for a long time, can often delay onset of menses. And even though they have an increase in height, it's not necessarily met with an increase in strength and neuromuscular control, which is obviously problematic. And this can be influenced by hormones, nutrition, and exercise. And then with strength and flexibility. So rate of bone growth, like I said, exceeds your muscle and tendon growth, which leads to this loss of flexibility and maybe ligamentous changes, which leads to an imbalance. A lot of times this is frustrating. And yet you see pictures like this, it always seems impossible until it's done. Who should be doing that? Nobody. There's zero people that need to be doing that. But these little girls are seeing that this is what they're supposed to be able to do. So if you do have a dancer who is hyper flexible, they need to learn good proprioceptive feedback so that they know, oh, I shouldn't put my body that far into this range of motion. Compression shorts and compression tights exist that can help with some proprioceptive feedback. And so can kinesio tape. That's a really good option to just give them a little bit of reminder. In terms of joint hypermobility, obviously the Baton 9-point system of flexibility testing can be used. So on the left, you can see the score, and you get a point for each thing. And then if you're less than 3, you're tight. If you're 4 to 6, you're kind of in the normal to mobile range. And then if you're 7 to 9, you're extremely hypermobile. Of note, though, it's been shown that if you take away the requirement of that last one there with you have to put your hands flat on the floor with the knees extended, dancers are sometimes not more likely to be hyperflexible than the average person, which is kind of interesting. These 3 guys all more flexible than the average person. So in terms of preventing injury, so there's inherent muscle imbalances that exist. There's strength training that usually happens only in parallel, but dancers don't exist only in parallel. And then we have to remember that we have to strengthen, therefore, through that range of motion that they dance through. When it comes to neuromuscular development, the main goal should be motor skill development to decrease injury risk. And if they don't have diverse activities occurring, how are they going to manage those neuromuscular skills? So do other forms of dance count as diversification? I don't know. Nobody's really tested that. Can we incorporate strength and conditioning coaches into dance schools? Maybe. I don't see why not. They have it for football. Why can't they have it for dance? And what happened to gym class? I don't have kids, but I feel like no kids do gym class anymore. Maybe we need gym class again. So in terms of alignment and movement patterns, so there's this whole concept of the anterior versus posterior pelvic tilt and tucking. So what is tucking? So tucking involves lumbar hyperlordosis to allow for pelvic extension. But why would we do that? So basically, in order to get that extreme turnout or that great external rotation of the feet, dancers will compensate by pronating their feet, rolling them out, and then screwing their knees or flexing them to get the foot turned out as far into 180 degrees as they can. Then they'll lock their knees up in position like Lucy was doing here, and then return the knees to that fully extended position and then tilt their pelvis anteriorly, which will cause that hyperlordosis like we see in this guy here. And then they'll tuck that pelvis under to try to flatten the spine to make up for it. So it'll try to look like a stable pelvis. So this little girl on the far left, you can see what a tucked pelvis looks like. versus a stable pelvis. And they're obviously very different looking, but a lot of them will try to do this tuck thing to look like they have good turnout to make up for some of that lack of range of motion. And in terms of timing, so in most sports, your risk of injury is higher during competition than in training, but that's not the case with dance. They train for so many more hours, and so they get these repetitive little micro traumas that just build up over time until it gets to a point of major trauma, and that's when it usually gets taken care of. So we need to consider scheduling rest periods maybe for these guys. More than 15% of injured dancers in a study stated that they did not report their dance injury. And the two most cited reasons for not reporting it is pain is just part of dancing and I can cope with it. And those are both really not great ways to think, right? You are guaranteed to have pain during your career as a dancer, yes, but you have to be able to recognize between what's good and what's bad pain. Good pain is like DOMS, a little bit of delayed onset muscle soreness, a little bit of body aches following an intense workout. Sure, that's okay. But if you're having tingling, prolonged ache, stinging, numbness, loss of strength, those are important things that need to be dealt with and dealt with soon. The other thing that's really interesting is high pain thresholds during the early years in a dancer's career can actually lead them to push through injuries to the point where their bodies become oversensitized. And so what happens is as they age further, they experience a decrease in their pain threshold with regard to the amount of pain that they can push through before they have to cease and rest. And so being able to understand that pain experience and pain tolerance is important to both protect their career and help them understand why it's so important that we know as healthcare providers about their pain. And then burnout syndrome. So a lot of adolescents tend to have a psychological component to dance because they have to self-identify as dancers so early on, it becomes part of their identity. I think COVID's really affected a lot of dancers because they haven't been able to dance this year. And so there's also, again, parental pressure, coach and instructor expectations, and these kids tend to kind of self-select for being perfectionists. So we need to figure out ways to help them cope with stress. And so, psych is important in this. And, even as a sports medicine provider, I work with a sports psychologist very closely because of that. This is a study on pediatric dance injuries and just goes over the epidemiology in terms of the most common diagnoses we see. And we're going to run through some of these. So there's obviously a lot of long-term health consequences that exist. And then in terms of energy balance, reminding a dancer that intake needs to equal output in order for them to be at peak performance and reduce their injury risk. Anything below or above that is not going to be the best for them. You have to remind them that they are athletes and need to be able to perform like athletes. And then with nutrition, so not as much as it used to be, but still a problem today. Pressures to remain thin exist, okay? This can lead to increased risk of stress fractures and poor muscular control due to the female athlete triad or REDS. And so having sports nutritionists and education regarding caloric intake, having a sports endocrinologist involved, things like that are really important to a good practice. So in terms of what is REDS, so REDS is relative energy deficit in sport. It used to be called female athlete triad. They broadened it to include men because men can have most of these problems, not all of them, obviously. It basically involves disordered eating that results in low energy availability, which then can lead to amenorrhea or a loss of their period in females, and then osteoporosis and low bone mineral density, all of which can just have a cycling effect on themselves and lead to problems down the road. Typically, dancers need about 1,400 kcals just for their resting metabolic rate, and then 200 kcals per hour of dance. So if they're dancing 3 hours a day, then they need about 2,000 calories per day, at least. And I don't know a lot of dancers that eat that much right now. And in terms of bone mineral density, so 90% of women's peak bone mass is accrued by the age of 18 to 20. So if they have inadequate lifestyle factors early on, they're kind of screwed for the rest of their lives. So we need to deal with this soon. Otherwise, we miss the boat for good enough bone mineral density and bone health. The greatest risk factors for stress fractures are having low bone mineral density and a BMI of less than 21, and participation in a leanness sport, which dance is still considered, and dietary restrictions, all of things that involve this female athlete triad, or READINESS. And then this is just a study from a little while ago, but she did talk about food diaries and trying to do that to help with noting whether somebody has negative energy balance, because they might not necessarily look anorexic, but still have a negative energy balance. So point work, this is really important. So point is that fancy part of ballet where they're up on their tiptoes, and the International Association for Dance Medicine and Science guidelines from 2009 said they should not dance on point before the age of 12 as a general rule. So this little Doreen Woods, age 4 on point, should not have been dancing yet. Generally speaking, we don't want them on point unless they are anatomically sound, meaning they have sufficient ankle and foot plantar flexion and range of motion. If they're not truly pre-professional, there's not really any reason to do point training. If they have weak core muscles or legs, or delay if they're too hypermobile, because then both of those things need an increased strengthening program first. And then if they're only taking ballet like once a week, again, it's not worth it to go into point. If they're doing more than twice a week ballet classes, then you can consider beginning it kind of in their 4th year of training. And there are males on point now. So those legs right there belong to James Whitehall, who's hilarious, but he does a lot of dance on point now. And then there's Ballet Trocadero, sorry, and they are an all-male point group. So Richardson did this functional criteria for assessing point readiness, and this can be really helpful. It shows some of the functional tests that they use for trunk control, including the airplane test, which you see at the bottom there, the topple test, and the saute test. Okay, so ballet feet are banana feet, right? So these are the Svetlana here has like the perfect ballet foot, but not everyone has this foot. So a lot of times if they have limited range of motion in that first MTP joint, then it's basically a non-starter, because then they can't get up onto that demi-point or up on releve, and it can cause them to have a lot of compensatory mechanisms that may increase their risk for injury, like the sickling you see here. And then anytime you are getting x-rays, if you're worried about something involving the ankle, you might want to try getting them to do their x-ray in the position that they're typically in when their ankle hurts. So that's what those x-rays are right there. Okay, so dance injury types. Majority of injuries involve the lower extremity. There's a couple breakdancing styles that have a lot of upper extremity injuries, but more or less a third are foot and ankle, a third are knee, and a third are miscellaneous. In males, it's lifts and leaps as a general rule. This is Jaden Energy Christian. So we are friends on Instagram. I don't know why. We just are. We started following each other, but it's fun. She does some crazy stuff, and that's called bone breaking. So this is a form of breakdancing, basically. Obviously, she is very flexible and probably has dislocated her shoulders in the past, and I don't want to know how many times, but we tend to see with the upper extremity injuries, dislocations, sprains, impingement, cuff, epicondylosis, and then restraint. So just like you'd see in other athlete population. In terms of the lower extremity, so ankle sprains are for sure the most common dance injury as an overarching theme. The most common mechanism for this is landing in plantar flexion and inversion, or on another dancer's foot after a jump. So kind of like the same way a basketball player when they come down from a rebound. And repeated low-grade ankle sprains is obviously going to lead to significant ankle instability. Treatment, I think you guys know a lot of these, but some regenerative medicine options have come into play more recently. So platelet-rich plasma or prolotherapy can be used. And then just remember that ankles really like to move, right? So rehab involving toe-ups, ABCs, and then even making them do stability training. So brushing your teeth twice a day, standing on only one leg. If we can prevent it and keep the ankle strong, we're better off. So those foot intrinsics matter. This is just a really cool thing to show you here. This is an ultrasound that I did on a couple of feet, and then a dissection I did. So ultrasound can be really useful in diagnosing ligamentous injuries. So this is me doing a stress test on a ATFL, which is clearly intact, but you can see some fluid bubbling down here. And then this is just a cadaver showing the ATFL in all its working glory right there. So it's pretty rad what we can do with ultrasound. But again, ultrasound's super user dependent. So it definitely depends on who's doing it. But we can also do stress views and measure the distance between to see if there is a tear. And then this is the same thing with the CFL. So it's another ligament that we can see really well. So in our dance populations, I'm scanning feet a lot. All right, plantar fasciitis. So we see this in normal population. A lot of runners get it, but we can see it in dancers as well. This is an overuse injury, obviously that involves the sole of the foot. And the onset of pain is usually after long weight-bearing activities with non-sprung floors especially. So if the floor that they're dancing on is like an old church basement or something, it's probably not a great floor. Treatments involve stretching, ice, golf balls, water bottle, massage underneath the foot, obviously getting some support for the foot, intrinsic foot strengthening. Injections are options, but again, be careful with what you're injecting. I will not put steroid into a plantar fascia, and I will not put steroid anywhere near a fat pad because it can break down the fat pad. Night splints, if it's chronic, there's a procedure called a percutaneous ultrasonic tenotomy, which that was the group that I mentioned at the beginning with my disclosures. But basically, that's a microinvasive surgical procedure that we do that we use for chronic tendinopathy or fasciopathies that are recalcitrant to conservative measures. So if they just are not getting better with anything else, that's an option for something like this. And then again, platelet-rich plasma or shockwave therapy or extracorporeal shockwave therapy can be really helpful here. It hurts a lot, but it can be really helpful here. Prevention, obviously, you want them to have a strong foot. And then Achilles tendinopathy. You guys are very familiar with this, I'm sure. Be able to recognize between tendinitis versus tendinosis is really important. Tendinitis is acute, tendinosis is chronic. They're managed a little bit differently. You don't want a career-ending rupture in these people, so they do have to have a little bit of relative rest. Stretching, very important, but you don't want to go beyond the point of comfort. Eccentric strengthening, shockwave therapy, tendon scraping or that percutaneous tenotomy that we talked about, and then just training a little bit smarter. Ankle impingement, super common with our ballet dancers, but really anybody that goes down into a plie or flexes their, dorsiflexes their ankle or plantar flexes their ankle a lot can end up with ankle impingement. The anterior one usually happens on the lateral side, and it leads to kind of scar formation and synovitis. And then the posterior one's usually from a bony irregularity like an os trigonum. So sometimes we have to inject these, sometimes we remove them surgically, but basically what we're trying to do is figure out where it's coming from, first of all, the os trigonum or a stiata process or an osteophyte. And so MRI can be really helpful here. Ultrasound can be used. If you are going to do an injection, I really recommend it's done with ultrasound guidance because we don't want steroid going into tendon tissue. We want it only around the area where the pain is. And flexor hallucis longus tendinitis or dancer tendinitis has been reported with 63 to 85% of these symptomatic os trigonums. So that's something else. When we try to manage these, it's modifying their releve height, seizing point work for a little while, working on talocrural joint mobilization, extrinsic muscles. Short-term NSAID use is okay, but I try not to use NSAIDs too much for a long period of time. And then ankle motion control with a walking boot for a short period can sometimes be helpful. There are surgical options, and then they end up non-weight bearing for a little while, so it's not great mid-season. This is just a classification of the causes of posterior ankle impingement because there's a ton of them. I'll leave that for you to review on your own. Dancer's fracture is doesn't only happen in dancers, but it's very common in dancers. Basically, it's an avulsion fracture at the fifth metatarsal with landing on an inverted foot. And so they end up fracturing at the tubercle and have immediate pain and swelling. They can't do a hop test to save their life. It hurts. You usually put them in a walking boot or a cast. And I do not put them in a Darko shoe. And the reason, or a post-op shoe, the reason you do that is because your peroneus brevis attaches to that tubercle of the fifth metatarsal. And so you're not actually completely resting it because you're still going to be able to evert in a Darko shoe. The other thing that we see in dancers that we don't tend to see in a lot of other athletes is a fracture of the base of the second metatarsal. But you treat it like you would any other fracture. Limit weight bearing, PT, get stronger. Okay, hallux valgus. So we've seen this in old people, but it happens in significantly younger age in dancers than the normal population. It's basically gradual onset, and they end up getting this constant rolling in during the turnout position, which leads to kind of bony overgrowth, causing a bunion. Treatment, you got to offload that area and send them potentially to surgery, but you don't want to lose motion because otherwise they lose performance. Same thing with hallux rigidus. So this is a really frustrating injury. So in order to achieve full demi-point, you have to be able to get your MTP joint to 90-degree angle. If you have hallux rigidus, you have pain and restriction of movement at that MTP joint. And so you can diagnose it with x-rays or ultrasound. So this little picture down on the middle of the screen is actually my great toe on my right foot. So I have hallux rigidus, and it looks like a shark fin, which it should not look like. It should look like a beautiful, normal, rounded joint. And so this is really frustrating because you can ice it and stretch it and modify shoe wear, but eventually people tend to end up with this massive amount of inflammation in the joint, and you can try injections, including corticosteroid, which will only help manage pain, or maybe prolotherapy to try to create a little bit of a healing response. But some people end up getting chelectomies, which is the surgery to remove those spurs, and it's basically career ending. I cannot get up on onto a demi-point anymore on my right side, so I can speak from experience on this one. The sesamoids, so they function to deflect pressure from the great toe flexor tendon, right? So for your FHL, and if you get sesamoiditis, it's just inflammation of those tiny bones. And so if they have too much pressure, you can end up with injury. And the treatment just depends on what the cause is, if it's a fracture, a stress fracture, or inflammation. So a lot of times, make sure there's imaging that helps you make the diagnosis, and then you might have to immobilize, consider taping the toe into a little bit of plantar flexion so that you're not getting that full dorsiflexion of the MTP joint. And if they do have a stress fracture, I don't like NSAIDs, right? We want a healing response to occur, and generally we don't need surgery unless all other conservative measures have failed. So dancer's tendon, I mentioned really briefly, but that's that FHL tenosynovitis that has that close relationship to posterior impingement syndrome. This tendon passes between the medial and lateral tubercle of the posterior talus and then travels down along the plantar surface of the sustentaculum tali. And it is exacerbated by being on point all the time, as well as like jumps or being in the 5th position in dance, or being on releve. You can also get stenosing tenosynovitis of this tendon, which is pretty unique to dancers, and we don't really see it in the general population because nobody else is just walking around on their tiptoes all the time. Treatment for this, physical therapy, ankle stability, NSAIDs are okay for a short period of time, activity modification, orthotics can be helpful, plus minus modalities, and then really good cross training. And making sure that they're wearing really sturdy running shoes when they're not in their dance shoes can be really helpful. This is just a phases of management for foot and ankle injuries from Vossler et al. It's really good just to go through kind of the rehab phases, and you'll note that there's not too much that's related to what the physicians are doing, but more related to what the rehab involves down the road. So the PTs, ATCs, this is your go-to. So you might say, but Dr. J, what about steroid injections? They feel so good. No, I don't like them for most cases, especially if we're looking at a tendon. I'd say in probably 95% of cases with dancers, I will not put steroid anywhere near them because we're just going to potentially weaken the tendon. You're going to cover up pain, and these people are already known to kind of work through pain. So if I cover up their pain, they're going to feel great, and then they're not going to know when they're hurting themselves. So I don't like. All right. Medial tibial stress syndrome. So shin splints, you guys know these. You manage it the exact same way as you would in any other athlete. If there is a stress fracture, though, you obviously have to get them non-weight bearing. if you have high suspicion for a stress fracture, but you don't see it on x-ray, you can get an MRI, or you can plan to just put them on crutches. I can guarantee you most dancers will ask you for the MRI because they won't want to be on crutches unless they absolutely have to. And I have used bone stimulators in the past. The research is mixed on it, but people that use them tend to seem to like them. Really need to work on core with these and improve their biomechanics so that this doesn't continue to be an issue for them. In terms of patellofemoral knee pain, so basically if they have a sudden increase in training frequency, they're going to get some anterior knee pain potentially, especially from compensatory issues with distribution of agonist and antagonist muscles. They tend to get like kind of a crepitus-y noise in their kneecap and have some problems with stairs, plies, and jumps. And treatment, obviously good core strengthening, looking at their biomechanics, single leg squats, and then proprioceptive feedback. So K-tape is actually pretty good here. I don't like bracing people, but if you're bracing for proprioceptive feedback, it's not a terrible idea. Basically, you need to work from the ground up. Address the ankle instability, work your way up towards the knee and the hip. And then this kind of goes for jumper's knee as well, which is patellar tendonitis. Okay, dancers tend to have hyperextension of their knees, right? A lot of them. And so they tend to find this to be like a fun party trick that they like to use, but we have to be careful because they will lock their knees out to try to help with that extension. And so they tend to be a little bit lax, and we might see things like this. So really look at your dancers and do like a good alignment evaluation when you see them in clinic. In terms of ligamentous injuries, so usually these are obviously traumatic in nature and can be pretty career ending for a lot of dancers. However, dancers don't really show the same kind of outcomes in terms of ACL findings, especially the females, as other athletes do. And the thought on that is maybe because generally speaking, ACL tears happen with poor jump and landing dynamics and fatigue and poor strength and motor control. But dancers aren't trained normally. They train in something that involves established ways of landing, not just jump in the air, try to head the ball and land somehow. And so they seem to suffer fewer ACL injuries than other athletes. So maybe it's because of this jump training. In fact, this research shows that in a typical 1.5 hour ballet class, they incorporate over 200 jumps, with more than 50% of them being single leg landings. So maybe with our, just in general with our ACL athletes, we need to think about doing a lot more glute activation, single leg jump exercises, repetitive landing techniques to try to help with that. So that's kind of interesting. And in this study, they found that dancers actually had better glute max activation and contraction than the normal non-dancing public. In terms of the hip, so hip injuries are likely in dancers, obviously. They have a lot of repetition and extreme ranges of motion, and they're susceptible because of all the jumps that they do. This review from 2017 found that approximately 17% of dance-related injuries happen in the hip or groin, and 85% of those are overuse and tended to be tendinitis of some sort. I'm going to list just two of the main ones here. So snapping hip tends to be something that we see more with dancers than the general public, and that's just because they put their hip in positions like that. So that's développé à la seconde, or doing a grand battement, so which is a big kick. Basically, it's usually painless for them, but that doesn't mean it's not a problem, right? It can happen in two places. Either you get an external one or a lateral snapping, which involves the IT band over the greater trochanter, or you get an anterior hip snapping that's associated with the iliopsoas tendon passing over the bony prominence on the front of the pelvis or the femur. If it is painful, lots of stretching and harnessing better control of the hip is really important. And then gear towards strengthening those deep hip external rotators, so that Bermuda triangle of the posterior hip with your gemelli and piriformis and obturators, all those things are really important for stabilizing the hip and kind of helping it stay in that socket as best as we can. And then labral tear. So generally labral tear is not a huge deal, but with dancers it can be really problematic because A, it can cause snapping hip, You can also have foreign bodies that show up in there, so it can feel stuck and they end up with impingement or limited range of motion. And then in terms of treatment, yes, there's conservative options, but you can try PRP, platelet-rich plasma, to try to force a little bit of a healing response, because surgery for them sometimes can be really problematic because they might end up tightening the labrum a little too much that they'll lose some of their external rotation. So it's just something to think about in this population more than I think anyone else. And then apophysitis, I said I'd mention this. So in our kids, apophysitis, these apophyses are vulnerable areas of bony growth, which is kind of where cartilage and bony attachment of tendons occur. And they are 2 to 5 times weaker than the surrounding structures, right? So when it comes to these, we tend to see localized swelling and pain that worsens with resisted activation and associated muscle tendon complex. It usually happens in the lower extremity in dancers. Patellar tendon can have Sinding-Larsen-Johansson or Osgood-Schlatters, which I'm sure you guys have heard of. And then calcaneus can have Sever's disease. And then the base of the 5th metatarsal can have Island disease. So these are things that we see a lot in dancers. Radiographs are really helpful. Ultrasound can be helpful too to find those issues. And then in terms of treatment, we need to prevent overuse and make sure that they're really well warmed up before they do things. And it's ballistic movements that can be problematic. So kick dancing, like anybody who does a lot of high kicks, or even our gymnasts will have issues with this because they have these quick ballistic movements that can actually pop the apophysitis off. Little kids, adolescents generally don't get tendinitis, they get apophysitis, right? The bone is weaker than the tendon, please remember that. Okay, and then just really quickly on the spine. So the spine, males are way more affected than females because they do stuff like this generally with dance. And the lumbar is the most affected, followed by cervical and then thoracic. And the more severe injuries tend to happen in men. There are, I think a lot of these are things that are managed with general rehab with any other athlete too, but a lot of it is choreography can cause weird ranges of motion that are expected of the neck and paraspinals, and so they can get muscle spasms really easily. And then anytime they have a growth spurt with the muscular growth leg, they're going to see spasms too. So they might have a lot of trigger points, so dry needling can be really helpful here, or trigger point injections. It can resolve with massage, icy hot patches, things like that. Discogenic back pain, you want to be as conservative as possible with this. You just need to maintain lower back flexibility. It's really bad with lifting, obviously, too, and it takes up about 40% of the mechanical back pain. Radiculopathy we see most commonly in L5-S1, which usually affects the S1 nerve root. So they get numbness and tingling down the back of their leg. Treatment is kind of the usual, Tylenol, PT, muscle relaxers, can be used judiciously. I've seen surgical discectomies done to improve pain, but even if they do those, they didn't really see a difference in terms of benefit 2 years down the road. So I don't really recommend surgery for these unless they have red flag symptoms, like they're, having cauda equina syndrome or peeing on themselves without realizing it. That's a problem. MRI if they have more than 6 weeks of pain. And then spondylolysis and spondylolisthesis. So these are just stress reactions to the pars that can involve either just a stress fracture or that involve actual forward translation of one vertebrae on the other. It's pretty common in dancers because they do so much work in extension, and they usually are really tender. This is a grade 5. This is not something you can dance with. This needs to be fixed very badly. But a lot of dancers can dance safely with a grade 1 spondy, so that's not the end of the world. But just really working on core strength is important there, and having good radiographs. If you can't see it on a radiograph and are really suspicious, then CT, SPEC, and maybe even MRI can sometimes be used, but MRI does seem to have a high false positive rate. And then you guys know the treatment options for a lot of back pain. I don't like NSAIDs for spine bony problems. And again, because you're going to have a risk factor for failure to heal here. So really good strengthening and stretching program. Limit some of the extension-based work that they're doing. it can take a long time. So just really being there for them can help. And if they're skeletally immature, get x-rays every 6 to 12 months. Facet joints, I think you guys know pretty much, so you can read on your own. And then sacroiliac joint dysfunction tends to be worse with jumping, hyperextension. X-rays are usually pretty normal unless they have sacroiliitis, which is going to show inflammation in those joints. And then core and pelvic girdle strengthening, you can use NSAIDs for a short period of time here because it's not a fracture. Fluoro-guided steroid injections are okay. Medial branch blocks with RFA for refractory symptoms. I will say we don't do that in our young dancers because you basically knock out those peripheral nerves, or the nerves that give you sensation to your back. But in some of the older dancers, it might not be a terrible idea if they can't tolerate anything else. And then trauma, finally. So traumatic injuries are very uncommon in dancers, except for maybe break dancers, because they do stuff like this, right? This guy just spins on his head all day. So, oh, it's not showing, sorry. Breakdancing neck is a real thing. And basically it was defined because there were cervical spine injuries that happened to dancers, ranging from like tetraplegia to just a cervical strain. So obviously, oops. Obviously, you need to make sure that they're being safe, they have good strength, they don't wear protective equipment. Breakdancers don't do that. Yeah, this is some of the strengthening control stuff that you don't want to have them do. So no tucking, tipping, tilting, or twisting of the pelvis. And then stability training, you can go through yourself, but these are some of the muscles that need to make sure that we're stabilizing. The core is important, and the rectus abs are not true core muscles. You guys all know that. And then just one little quick point, I guess. So in this month's episode or edition of Dance Magazine, we talked about COVID-19. So there was an article written by Garnet Henderson that was called Dancing After COVID-19. And she interviewed me, and it just has some recommendations on returning to dance after COVID for our dancers, because there's a lot of chronic injuries that are popping back up now that they're getting back into dance. And then there's also the post-COVID syndrome thing that we don't really know about. So looking out for those types of things are important. Martha Graham was a great woman, and she said great dancers are not great because of their technique, they are great because of their passion. And I agree, except for they stay healthy because of good technique and biomechanics. So making sure that we monitor these dancers for this is really important, and good prevention is really important. So conditioning, functional performance testing, finding risk factors early on, recognizing risks for nutritional deficits, and instruction for dancers, dance instructors and parents is very important. And then on a secondary side, making sure that we have a good comprehensive approach. So we should be working in a team effort to deal with some of these injuries. Basically, this is just showing that most of these accidents happen in the first 3 hours of beginning practice. So we need to focus on organizational structure and developing like good work environments for dancers. And then I think we need pre-participation exams for our dancers because we do them for all our other athletes and not them. So that's something to consider. And then my last little plug, goals for the provider. Do not tell a dancer to stop dancing, because unless it's an injury that requires complete rest, like a fracture. But otherwise, they're just gonna think that you don't care about them and you didn't listen to their problems. Dance is, for a lot of them, an identity, right? You identify as a dancer, and if you lose that identity, it can really crush your soul. So primary prevention strategies is important, secondary prevention strategies, and then educate that dance community. And again, comprehensive management programs through all of us. Resources for you, references, thank you. Sorry, I went over.
All right, awesome. Well, thank you so much. That was definitely a lot of really good information there. If you do have questions, don't hesitate to post those into the chat, well, into the question tab. And the first, it looks more so like a comment coming from Alan, talking about with the sesamoids, differentiating between a bipartite sesamoid rather than an either acute or chronic sesamoid injury. He talks here also about taping bunions to be able to continue to get into a point shoe. And then he also talks about traumatic labral tears He says that traumatic labral tears tend to do better than chronic ones.
Yes. So with sesamoids, yes. So some people have a bipartite sesamoid. Usually it's like a very nicely clean separation, and you can x-ray the other foot as well to compare bilaterally, because sometimes they'll have it bilateral, whereas a fracture they shouldn't have bilateral. However, sometimes it can be really difficult, and so you might even need to consider getting like a PET scan to look for a hot spot or something like that, or you just try taping them. I will use ultrasound a lot and put Doppler on it to look for hyperemia. So if it's a fracture, I'd probably see a lot of inflammation and maybe some edema around the sesamoid, whereas if it's just a bipartite, it should look stone cold normal. So those are ways that you can differentiate. The taping for the bunions. So yes, there are tape jobs that exist. It's really hard to get into a point shoe afterwards. A lot of times dancers are like so specific about how they want their point shoes to fit them too. They've got like little bits of mesh between their toes, and they've got, you know, fabric and gauze and whatever. I didn't do point, I hated it. But they will use these things, and so it'd be really hard to find a good tape job that does work unless they have like a bit of a bigger toe box, which could be detrimental to the other foot. So they almost have to have two pairs of shoes that maybe one has a little bit wider of a toe box that can fit that tape job, if that's the case, as long as they fit them well. Other than that, a lot of times I just tell them you can't do point right now until we get this thing under control. And then with the labrum, I don't know if that was just a question or a comment. So yeah, traumatic ones versus chronic ones. So chronic ones, I mean, again, if it's traumatic, they tend to do really well with PRP actually, because it's, you know, an acute injury. It's usually in a younger person. It's not degenerative, and we can expect to see pretty good healing response. Whereas chronic overuse ones or degenerative changes, those ones have been there for just so long, and they've got all these little tiny cuts in them kind of thing. So those are a lot harder to surgically repair for sure. Traumatic ones are easier to surgically repair, but again, we have to be worried about that tightening of that capsule. I hope that answered that question.
Yes, it certainly did. And it looks like we are out of time today. So if you do have questions, don't hesitate. You can send them to us. I know my email address is in the information. Is there any information that you want to give to everyone before we conclude for tonight?
Sure. So yeah, if you have questions, you can email me at ji2253@columbia.edu. Otherwise, my work Instagram is at Columbia Dance Medicine, so that's super easy, and I'll respond to you on there. Or Twitter is at the new Dr. J. And we're building this dance medicine program, this performing arts program at Columbia, which is really exciting. So anybody who has any interest in doing some collaborations in terms of research, I think we would love it. We're always, willing to collaborate to help our dancers out. So thank you for having me, and thanks for listening.
Have a great night, everybody.